My name is Marianne Brodmann. I'm from Graz, Austria, from the Division of Angiology at the Medical University here in Graz, Austria. The reasoning behind that is that, especially in iliac arteries or iliac arteries, endovascular revascularization plays really a crucial role. We know that bare metal stents have been used there for years, but long-term data on cobalt chromium stents in the iliac artery disease is limited. And therefore, the BIONETIC study evaluated this unique feature of a cobalt chromium stent in the iliac artery field. The Biotronik stent, with regard to the stent sizes, they have a very good sheath compatibility, only 6 French. So they have a low entry profile, and this is really important, especially in the iliac arteries. They have a double helix stent design, and with regard to the coating they have applied, it reduces the ion on release. And with regard to this, it's a very unique scaffold. You can also use it for radial approach, which is very common right now, especially if you treat iliac arteries. So it's, with regard to all these kind of things, a really new stent design. So it was an international multicenter prospective non-inferiority single-arm study with 160 patients included in 15 sites in 6 countries. The follow-up is up to 5 years. And we could include all kind of patients with Rutherford category 2 or higher. We could include patients with de novo, restenotic, or occluded lesions. The only feature, it needed to be more than 70% stenosis in the iliac arteries. So the only exclusion criteria, which I really think is worthwhile to mention, is instant lesions. So we could not include instant lesions. And with regard to the primary endpoint, it was the rate of major adverse events at 12 months. And there were also a lot of secondary endpoints like rates of clinical driven DLR and all the study endpoints, primary patency, changes in Rutherford category ABI, and also, and I think this is very important right now in studies, the quality of life improvement and the walking impairment improvement. With regard to the key findings, at 12 months, so I want to start with that. The primary endpoint at 12 months was met. So the major adverse event rate at 12 months was only 3.5%, meaning that on this major adverse event endpoint at 12 months was a composite of device or procedure-related death within 30 days, both procedure, clinical-driven TLR, and major limb amputation. So this was really, really outstanding. And also at 24 months, we had a freedom from major adverse events up to 93%, nearly 94%. And with regard to freedom from clinically driven TLR at 2 years, freedom from clinically driven TLR was 90%, 95%, and primary patency 82.6%. So these were really, really good endpoints. And this was also, how to say, or you can also see that with regard to survival, which is very good, or freedom from major target limb amputation. And you have to take into consideration that around 13% of the patients in this study were patients with critical limb ischemia. So I think this is really good outcome data. The take-home message for practice is that this is a good working scaffold in iliac arteries with a very good profile. You can use it also for transradial approach. Has very good outcome data, has a very low excess site issue. So I think this is something with regard to daily use and use on a regular basis. Very, very, very good tool, in my opinion. In the pelvic area, I think what is really needed is the focus on the calcium in iliac arteries. What kind of vessel preparation treatment, or do we need that? What is the drug? What is the relevance of drug therapy in the iliac artery or in the pelvic region? Then should we stay with should we stay with bare metal stents, or should we maybe move on to drug-eluting stents or bioresorbable scaffold. So I think this might be of some interest in the next years.